Dr. Latha is a professor of anesthesiology in Savita Medical College. She's been a postgraduate teacher for the past 28 years, and she has various presentations in national and state level conferences. She's been a Tamil Nadu state level course coordinator for Tamil Nadu Accident and Emergency Care Initiative. Her special interests are in obstetric anesthesia and regional nerve blocks. Welcome, ma'am.
Thank you. Good morning, all. I thank all the organizing team to give me an opportunity. And today I am to talk on a very pertinent topic, anesthetic management of pregnant cardiac patients. Maternal heart disease is rising as an emergency situation, and it is the major important cause of maternal mortality in pregnant women. So managing these patients is very important. It is to have a safe motherhood and to have a long-term cardiovascular good health of the mother. Though its incidence is only 1 to 3%, it accounts for 15% of the maternal mortality. In developing countries, acquired valvular heart disease, especially rheumatic mitral valve stenosis, is still common, and in developed countries, due to better surgical outcome, congenital heart diseases are common. Coronary artery disease is on the rise due to advanced maternal age and the presence of coexisting comorbid conditions among pregnant women. There are certain cardiac lesions which have high morbidity and mortality. To mention a few are pulmonary hypertension, dilated cardiomyopathy with ejection fraction less than 40%, Eisenmenger syndrome, and severe stenotic lesions and patients with congenital heart disease. So efforts were taken to reduce the morbidity and mortality in the pregnant cardiac patients. This led to the development of the cardio-obstetric team, which identifies these high-risk patients. They do a pre-pregnant counseling for them, and they monitor them during pregnancy. They develop a delivery plan, and they provide care during the postpartum period. The cardio-obstetric team consists of the obstetrician, the cardiologist, the fetal medicine specialist, anesthesiologist, and critical care nurses. Even subspecialty department experts are included in the team as and when need arises. There should be a good coordination between the team members, and each one is allotted a definitive job. The team lead will vary over the course of pregnancy. We anesthesiologists, we play an important role during the peri-delivery time. As I told you already, we can get the help from the subspecialty experts as and when need arises. Pregnancy cohorts were all assembled and indices were developed to bring down the maternal mortality and morbidity. To mention a few are the NIHA, the ACOG, SOAP, the CAPRED, and the ZAHARA. A registry of pregnancy and cardiac disease is a cohort which was conducted during 2007 to 2018 over 60 countries, including 6,000 registrations to it. Data from ROPAC has been assembled, and it led to lesion-specific classification, that is modified WHO classification, which categorizes patients into low, moderate, and high-risk group. According to the functional classification of NIHA, class 4 patients are symptomatic at rest, whereas class 2 and 3 patients are mildly symptomatic on activity, and class 4 patients are severely symptomatic, and they need to be attended by the cardio-obstetric team in a level 4 centers. Risk stratification of these pregnant cardiac patients is done using modified WHO classification, together with or without CARPREG-2, which will add few more points to it. According to the modified WHO risk classification, class 1 and 2 patients are uncomplicated cases, and they have a mild increase in their morbidity and mortality. They are provided care in class 1 at level 1 centers under the guidance of the cardio-obstetric team, whereas class 3 patients are at a mild, moderate to higher risk, and they are to be provided care at level 3 or 4 centers by the cardio-obstetric team. Class 4 patients are very high risk patients, and usually pregnancy is contraindicated in them. If the mother insists on continuing the pregnancy, care at level 4 centers by the cardio-obstetric team with the support from the subspecialty team experts is done for them. Though, coming to CARPEG 2, this is a risk classification which takes into account the general condition of the patient, the lesion specificity, and the care variables. The cumulative points obtained will indicate the risk of the cardiac complications. Whatever the classification is done, none of them predict the absolute individual risk the patient is going to go through. So, monitoring them continuously during pregnancy is mandatory by the cardio-obstetric team. We are all aware of the physiological changes that occur in the cardiovascular system during pregnancy. In pregnant cardiac patients, there is an interplay between the pathophysiological changes which occur due to the underlying cardiac disease with the physiological changes of pregnancy, resulting in pathophysiological changes in the pregnant cardiac patients. Understanding these physiological changes, its anesthetic implications will result in better care delivery to these patients. There are certain warning criteria which have to be monitored during risk classification. When these are detected, patients are categorized at a higher risk and patients are referred to higher centers for further management. After risk stratification, a delivery framework is formed by the cardio-obstetric team to plan when, where, and how to conduct delivery. During the pre-pregnant counseling, patients are provided individualized care. They are risk stratified, and their patients are subjected to assessment of the effect of the cardiac disease on pregnancy and the effect of pregnancy on the cardiac disease and both its effects on the fetus. They are also briefed about the frequency of the antenatal visits they need to make and the diagnostic tools which they will be subjected to. And if the patient needs an anticoagulant, they are initiated and it is monitored in them. The patient are briefed about the time, the place, and the mode of delivery and the mode of labor analgesia we are planning for them. They are also updated about the postpartum monitoring and care which will be provided to them. The time of delivery is usually, the goal is to get an optimal newborn outcome, but it is usually individualized based on the severity of the cardiac disease, presence of comorbid conditions in the patient, the anticoagulation status of the patient, and whether the mother will need a surgical intervention in the peripartum period. Class 1 and 2 patients are usually provided care at level 1 centers. Class 3 and 4 patients are are recommended to deliver at level 4 centers. Pregnant cardiac patients who carry to term or near term are safer to go through a spontaneous vaginal delivery because the hemodynamic changes are gradual to occur and it allows time for accommodation and time for the care providers to provide care for them. And also the obstetric complications like infection, bleeding, and thromboembolic manifestations are also less. 1 minute. If the labor needs to be induced, oxytocin can be used and ARM can also be done. Dinoprosteron, which causes coronary vasospasm, should be avoided in them. If a patient is undergoing a vaginal delivery, it is usually assisted to decrease the force, effect of Valsalva on the preload. Prolonged forceful Valsalva will cause a decrease in preload, which is poorly tolerated by patients who have a left-sided obstructive lesions. It also will cause an increase in the shear stress on the aorta, which can precipitate dissection in patients who have aortopathy. The hemodynamic changes which occur in the peripartum period needs to be mitigated to get a better maternal outcome. The pain and anxiety of labor will cause an increase in catecholamines, and this will lead to tachycardia and arrhythmias. So, giving an adequate neuroaxial anesthesia will prevent these changes. The decrease in systemic vascular resistance could be because of the pregnancy hormones or because of neuraxial block or the postpartum hemorrhage will cause a decrease in coronary perfusion. This can usually be avoided by using vasopressors to increase the systemic vascular resistance. The cardiac output, which increases throughout pregnancy and it peaks in the 3rd stage of labor, can cause congestive cardiac failure, which is usually treated by diuretics, inotropes, and positive pressure ventilation. If need arises, patients can be put on an ECMO temporarily. When patient is undergoing a vaginal delivery, standard ASA monitoring to be given, especially in patients who are receiving neuraxial anesthesia. Invasive blood pressure monitoring is done in patients who undergo, who are having a critical valvular stenosis or patients who are decompensating. Use of CVP in pregnant cardiac patients is of low utility. If vasopressor administration has to be done for a longer time, peripherally inserted central venous catheters are preferred. If the patient needs a pulmonary vasodilator therapy, a pulmonary arterial catheter insertion is advocated. The labor analgesia will provide best benefits to decrease the hemodynamic response to pain. And it also acts as a conduit for cesarean delivery. Patients who are on oral anticoagulants should be properly be timed when you plan a central neuraxial blockade. Preloading should be avoided in these patients. Co-loading using small boluses of 200 ml cautiously can be administered in them. If you're doing an epidural test dose, avoid lignocaine with adrenaline. You can use 50 to 100 micrograms of fentanyl for intravascular placement or small aliquots of 0.2 1 to 5% of sensorcaine for intrathecal placement. If patients develop hypotension, use phenylephrine boluses or ephedrine boluses. For treating cardiac failure, you can use dobutamine or milrinone. If the patient is undergoing a vaginal delivery, and assistance of the vaginal delivery during the second stage can be done by augmenting the epidural block to block the sacral fibers. Cesarean section is usually indicated in patients only for obstetric reasons. Very few non-obstetric indications are there, which include patients who are on oral anticoagulants who come with preterm labor and there is no time for bridging, or patients who are decompensating or who will require a surgical intervention in the peripartum period. Class 1 and 2, modified class 1 and 2 patients are ideal candidates for a neuraxial analgesia. Class 3 patients also can undergo a neuraxial block, provided you use narcotic-based low-dose local anesthetic along with stringent monitoring. General anesthesia is usually given in patients who are decompensating or who are on current anticoagulation therapy or who have thrombocytopenia or when the mother refuses the surgical intervention. Always bear in mind, when the patient is on oral anticoagulants, warfarin antagonists do not cross the placenta and the newborn remains anticoagulated for next 5 days and it has to be monitored for intracerebral bleeds. In India, I'm to brief about few conditions which are common in India. We have the hypertensive disorders, the stenotic valvular lesions, pulmonary hypertension, peripartum cardiomyopathy, and congenital heart disease. Hypertensive disorders are the most common to occur in India, and it has low morbidity and mortality if due care is provided to them. The ventricular hypertrophy will cause increase in workload on the patient, workload on the myocardium, and there is a poor ventricular relaxation. Added together with a decrease in SVR and increase in heart rate, the coronary perfusion will come down. So our goal is to maintain a normal rate and rhythm, maintain adequate preload, and maintain the afterload. Monitor for any other complications like thromboembolism and avoid myocardial ischemia in these patients. As I told you already, mitral stenosis is the commonest occurred valvular heart disease among pregnant cardiac women. When the mitral valve area is more than 1.5 square centimeter with no pulmonary hypertension and when the pressure gradient is less than 2, they are safe to go through pregnancy, labor, delivery and the postpartum period. But when the women are with a mitral area less than 1.5 square centimeter with pulmonary hypertension and when the pressure gradient is more than 12, they are high risk group people. They have to be monitored by the cardio-obstetric team and they are shifted to level 4 centers where subspecialty team members are available. I'll take a few more minutes. We all know that mitral stenosis is a fixed low cardiac output state. And the decrease in oncotic pressure together with the increase in blood volume and heart rate will predispose them to develop atrial fibrillation and pulmonary edema. So our goal is to avoid tachycardia and atrial fibrillation, maintain normovolemia in these patients, and avoid fall in diastolic blood pressure, monitor and treat pulmonary edema whenever it is necessary. Pulmonary hypertension is one disease which causes high maternal mortality ranging from 13 to 33% depending on the severity of the pulmonary arterial hypertension. The increase in cardiac output is not accommodated in the fixed vasculature and patients do go in for congestive cardiac failure. The diastolic blood pressure and SVR decrease causes decrease in coronary perfusion and it precipitates right heart failure. They are also more prone to develop pulmonary embolism which can cause an acute rise in pulmonary hypertension. Our goal is to decrease the PVR by using pulmonary vasodilators like prostacyclin through the PA catheters or nebulization with iloprost. We should maintain a normal blood volume and avoid arrhythmias and tachycardia and factors which will affect, which will increase pulmonary arterial hypertension like hypoxia, acidosis. Peripartum cardiomyopathy is another one important cardiac disease which we come across in pregnant patients, and this is a heart failure secondary to severe left ventricular systolic dysfunction in the late third trimester or in the postpartum period. There is no identifiable cause in them. The increase in blood volume and the cardiac output together with a decreased oncotic pressure predispose them to develop pulmonary edema. The increased risk of thromboembolism is also there in them. So our goal is to avoid bradycardia or tachyarrhythmias in them, maintain a adequate preload, avoid hypo or hypotension, and monitor and treat pulmonary edema whenever it occurs. These are very high risk patients. Always have an intracardiac defibrillator at hand whenever you anesthetize these patients. Coming to the congenital heart diseases, acyanotic left to right shunts are usually well tolerated because the decrease in SVR will cause a decrease in shunt fraction. The increase in cardiac output and the blood volume will precipitate cardiac failure in these patients. So our goal will be to avoid volume overload and provide adequate labor analgesia and prevent paradoxical air embolism. You can use saline syringe for LOR detection and avoid exteriorizing the uterus during closure. Right to left shunts are poorly tolerated during pregnancy and they are high risk group and they have to be provided care at level 4 centers with subspecialty department experts. As I told you already, standard ASA monitoring, CVP and PA catheter as and when needed. Transthoracic echocardiography or FATE or focused cardiac ultrasound are all bedside tests which will help us in detecting the volume status of the patient, continuous monitoring cardiac output, and whether there are global or wall motion abnormalities, whether there's pericardial effusion, all that. TEE also will do the same job. It is done in patients who are intubated. Surgical site infection prophylaxis is given for all patients who undergo cesarean section. IE prophylaxis is given only in patients who have previous history of carditis or patients with prosthetic valves or who have had a shunt corrected with grafts and who have complex congenital heart disease and critical stenotic lesions. When a patient is due to receive a central neuraxial blockade who is on anticoagulant, stop the oral anticoagulants 4 to 5 days before and switch over to, bridge them with unfractioned heparin. If they are on low dose unfractioned heparin, 4 to 5 hours of gap, and for intermediate dose, a 12-hour gap, and for a high dose, a 24-hour gap is mandatory. If the patient is on low molecular weight heparin, on a prophylactic dose, stop it 12 hours before, and on for therapeutic dose, it is 24 hours gap. Always monitor the platelets, APTT, and anti-factor 10A before you subject them for central neuraxial blockade. Pregnant cardiac patients are also prone to develop postpartum hemorrhage. Avoiding major hemodynamic changes by due care during the third stage of labor by early active intervention using proper oxytocins, proper uterotonics and manual measures will help them to go through that safely. Oxytocin is a powerful uterotonic. It is given at a dose not exceeding 16 units per hour in non-labor patients and 44 units per hour in labor patients. Carboprost is likely to cause an increase in pulmonary arterial pressure as well as it causes bronchospasm. Methergin causes increase in SVR and PVR. Misoprostol is a weak uterotonic. Carbitocin when it is given as a bolus of 100 micrograms is effective for an hour, and it has least cardiovascular effects, so it's safer to be used in pregnant cardiac patients. If tranexamic acid is to be used, use it early, within 3 hours of baby delivery. Continue the same care and monitoring which was done during labor and delivery in postpartum period also, as these patients will undergo major fluid shifts and hemodynamic disturbances in the next 48 to 72 hours. Observe them for even mood disorders, that is also very common in them. To conclude, we anesthesia